So I will be talking about management of acute severe asthma and COPD, particularly uh, uh, concentrating the emergency department setting. First, we'll go through a small case scenario. We have a patient, Mr. X, 72 years old male, retired bus driver, with a history of COPD stage 3, group E, who is a frequent exacerbator, with a history of uh, smoking, which was stopped 2 years ago. His condition is uh, complicated with hypertension and ischemic heart disease, coming with increased shortness of breath, productive cough with purulent sputum, and wheezing for the last 2 days. Because this is emergency department, meanwhile you examine the patient and you find a dyspneic patient with a respiratory rate of 28 breaths per minute, tachycardic with heart rate of 110 beats per minute, blood pressure normal, slightly towards the high sides, saturation 88 in the room air. Patient is alert but anxious, using accessory muscles to breathe. Respiratory system examination revealed hyperinflated chest, auscultation, diffuse wheezes and coarse crackles. Patient had prolonged expiratory phase, cardiovascular examination normal, and there was no evidence of peripheral edema. So you have a patient with a history of COPD, ischemic heart disease, hypertension, old male patient, coming with increasing breathlessness over 2 days. What could this be? Because this is emergency department, you don't have much time to go through much of the information. So with the initial assessment of with the past history and all, the most likely possibility is exacerbation of COPD. However, possibility of in this type of patient, possibility of acute asthma, pneumothorax, pulmonary embolism, pneumonia in pulmonary perspective, and in terms of cardiovascular system, acute heart failure, acute coronary syndrome also needs to be considered. Apart from that, DKA, sepsis, metabolic acidosis also should be considered because all these can be killers. Particularly in young females and in young patients, if they are coming with the breathlessness and your examination is normal, you have to consider anxiety with hyperventilation as well. For our patient, arterial blood gas showed evidence of partially compensated respiratory acidosis. ECG showed sinus tachycardia, full blood count showed neutrophil leukocytosis with CRP of 46, showing evidence of bacterial infection. This is a chest X-ray which shows hyperinflation without consolidation. And for this particular patient, the diagnosis was acute exacerbation of COPD, likely triggered by bacterial infection. I'm not going into details of the management because we will be discussing this over the next 20 minutes. So the objectives of the lecture: to understand clinical features of acute severe asthma, emergency assessment and risk stratification, evidence-based management per GINA guideline, follow-up planning, and in terms of COPD, again, how to identify acute exacerbation, risk stratification and management, goal recommended treatment, and how to plan the discharge and follow-up. First, we will move on to asthma exacerbation. This is based on the GINA guideline 2025. What is the definition of acute severe asthma? Acute severe asthma is a life-threatening exacerbation requiring prompt treatment. Although this is rare, it represents major risk of mortality. So awareness and rapid intervention can save lives. Usual prevalence is around 5 to 10% of asthma cases present with severe exacerbations per annum. There are certain features of patients which can predict the risk of death with the exacerbations. If the patient has history of previous ICU admission or intubation history, they have higher risk of death. Patient having hospitalization or emergency care for asthma in the preceding year, poor adherence to inhaled corticosteroids, currently using or recently stopped course of oral corticosteroid, overuse of short-acting beta agonist, more than one canister per month, that is 200 doses of short-acting beta agonist, which has been used over the last 1 month. If the patient is having psychiatric conditions or history of confirmed food allergies, lack of written asthma action plan, all these are uh, can predict the risk of death. The GINA emphasizes protocol-driven approach. So rapid assessment, early bronchodilation, corticosteroids, and oxygen is required in the management. Treat first, but you can investigate second. Regular assessment is very important. In the initial assessment, you have to start with ABCs, measure oxygen saturation, respiratory rate, heart rate, assess ability to speak, level of consciousness. If you have the peak flow, it's important to perform peak expiratory flow. This is helpful, particularly if you have patients' previous personal best peak flow values. In terms of asthma exacerbations, you can divide this into 4 categories according to the severity: mild, moderate, severe, and life-threatening. The features of mild asthma attack includes patients talks in phrases, respiratory rate less than 30 breaths per minute, heart rate less than 100 beats per minute, peak flow if you have more than 70% of the predicted or patient's personal best. Moderate exacerbation, patients talk in sentences rather than phrases, respiratory rate 20 to 30 minutes breaths per minute, heart rate around 100 to 120 beats per minute, peak flow 50 to 69% of the predicted. If the patient is having severe exacerbations, they talk in words, respiratory rate less than 30 minutes, 30 breaths per minute, heart rate 120 beats per minute, more than 120, peak flow less than 50% of the predicted or personal best. In patients who are having life-threatening asthma attacks, you find the patient is drowsy, confused, having silent chest, patients may be cyanosed, saturation less than 90% in room air. If you measure peak flow, it should be less than 33% of the predictor. Use this classification to guide urgency of treatment. Severe and life-threatening cases need immediate intensive therapy and possible ICU care. In asthma exacerbations, any investigation is not mandatory. However, pulse oximetry is very important. You have to do it. If the patient is having features of severe distress, you can perform arterial blood gas. If the patient is not improving clinically with the initial therapy, you can perform chest X-ray to rule out complications. ECG if indicated. This is the flow chart of the management of exacerbations in primary care in the GINA guideline. So when you first see the patient in the primary care, you assess the patient, you assess the degree of severity of the exacerbation, which we discussed. depending on the severity of the exacerbation, you plan the further management. If the patient is having features of life-threatening asthma attack or features of severe exacerbation, you have to think of transferring the patient to acute care facility. For all patients, mild to moderate exacerbation or severe or life-threatening exacerbation, you have to start treatment with short-acting beta agonist. You can give this with MDI meter dose inhaler with a spacer. You can give 4 to 10 puffs at a time, and you can repeat this 20 minutes. Repeat this every 20 minutes up to 1 hour while reassessing the patient. So this is almost equivalent to your nebulization. However, you have to decide this depending on the condition of the patient. If the patient is not fit enough to take a spacer with the MDI with a spacer, you have to proceed with the nebulizer. So you have to start the patient on steroids early. For adults, prednisolone 40 to 50 milligrams per day. For children, 1 to 2 milligrams per kg up to maximum dose of 40 milligrams. So there are some key changes in the 2025 guideline. Of these, I like to highlight the recommendation on controlled oxygen. The recommendation for asthma in acute exacerbation is target saturation of 93 to 95% for adults and adolescents. For children, this is different. This is 94 to 98%. So apart from the nebulization with short-acting beta agonist, you can give some add-on therapies, including ipratropium bromide. You can, the usual dose is 0.5 milligrams per dose. You can give up to 3 to 4 day doses. The recommended maximum dose is for ipratropium is 4 doses of 0.5 milligrams per 24 hours. So you have to give the patient oral prednisolone, or if the patient cannot take oral, you have to give IV hydrocortisone. If the patient is not responding, you can treat with IV magnesium sulfate, particularly for life-threatening or non-responsive cases. The dose is 2 grams over 20 minutes. Each time you have to reassess the patient every 15 to 30 minutes. Assess vital signs, saturation. If you have peak flow, monitor the peak flow as well. So when do you decide to admit the patient to the ICU? If the patient is having persistent hypoxemia despite your management or rising CO2, if the patient is exhausting and having altered sensorium, not responding to treatment, you have to consider whether the patient needs ICU care. So one thing I didn't mention about the nebulization of the short-acting beta agonist, usual dose you can give is 2.5 milligrams to 5 milligrams of salbutamol solution per nebulization. So this is in the emergency department. So after managing acute exacerbation, if the patient is responding to the treatment, you can plan the discharge. If the patient is having saturation more than 94% in the room air, peak flow is more than 60 to 80% of the predicted, patient does not need any short-acting beta agonist for the preceding 4 hours, and the patient is having adequate resources at home to manage his condition if he goes into deterioration again, like if the patient is having a proper transport method or there is anyone around at home to look after him or her, you can plan the discharge. When you discharge, you have to make sure the patient is being given oral steroids, short course of 5 to 7 days. Continue short-acting beta agonist as needed. Restart control of with inhaled corticosteroid if the patient is defaulted, or you have to continue the inhaled corticosteroid. You may have to increase the dose depending on the patient's condition. It's in the optimal management, it's important to give asthma action plan, and you have to arrange follow-up visit in 2 to 7 days, and it's earlier for children. So what are the common pitfalls in the emergency department when you manage acute exacerbations of asthma? You may underestimate the severity. Delaying of the corticosteroid administration is another pitfall. Not giving ipratropium in severe cases, or failure to arrange follow-up or educate on discharge is also another problem, which can lead to recurrent admissions. That's about the exacerbation, acute severe exacerbations of asthma. Let's move on to COPD exacerbation. The definition is worsening respiratory symptoms beyond daily variation. Patient will have increased dyspnea, increased sputum volume, or increased purulence, developing purulence of the sputum. So what are the confounders or contributors to be considered in patients presenting with suspected COPD exacerbation? Patients developing pneumonia, pulmonary embolism, heart failure, pneumothorax, pleural effusion, myocardial infarction, arrhythmias, all these can contribute to development of the COPD exacerbation, as well as they can mimic. It's important to assess the severity again in COPD exacerbation as well. If the patient is having mild exacerbation, you can manage the patient as outpatient. Moderate severe exacerbation, patient should be managed in the emergency department or admit to the hospital. My apologies for the poor clarity. So this is the classification of the severity of COPD exacerbation. So you have a patient suspected COPD exacerbation, you confirm the diagnosis, and you have to assess the severity of the patient. So as I told, there are 3 categories: mild, moderate, and severe exacerbations. The features of mild exacerbation are, if you use a visual analog scale for dyspnea, patient will be having less than 5 in the visual analog scale of dyspnea. Respiratory rate less than 24 breaths per minute, heart rate less than 95 beats per minute. Excuse me. Resting oxygen saturation more than 92% in the room air. And if you check CRP, it's less than 10 milligram per liter. If the patient is having visual analog scale more than 5 for dyspnea, respiratory rate more than 24 breaths per minute, heart rate more than 95 breaths per minute, resting saturation less than 92 in room air, with CRP more than 10. If you have more than 3 of these findings, patient is having moderate exacerbation of COPD. When you call severe exacerbation, if you have all the features of moderate exacerbation with ABG showing new onset or worsening hypercapnia and acidosis, you call it severe exacerbation. Clinical features are the same, but with that you have evidence of hypercapnia in the blood gas. So when do you consider admitting to the hospital for further assessment and management? If the patient has severe symptoms such as sudden onset bursting of resting dyspnea, high respiratory rate, decreased saturation, confusion, drowsiness, features of acute respiratory failure, onset of new physical signs such as cyanosis, peripheral edema, failure of an exacerbation to respond to initial medical management, presence of serious comorbidities such as heart failure, newly occurring arrhythmias, insufficient home support. All these are potential indications for hospital admission. What are the risk factors for poor outcomes in COPD? History of previous hospitalization, again, a risk factor for COPD as well. Presence of comorbidities, patients having low BMI, and history of frequent exacerbations, all are risk factors for poor outcome. What are the investigations? You can do arterial blood gas. You have to do to check the patient is having respiratory acidosis, if the patient is hypoxic and features of severe exacerbation. Basic blood investigations, full blood count, CRP, BNP, depending on the patient's other comorbidities, you can decide this. Chest X-ray, ECG, point of care ultrasound, if indicated, depending on your examination findings. How do you manage severe exacerbations of COPD? Oxygen therapy is very important. You have to target the saturation, keep the target saturation 88 to 92%, and make sure you do not over-oxygenate the patient because they have high risk of hypercapnia. Short-acting inhaled beta-2 agonists with or without short-acting anticholinergics are recommended as the initial bronchodilators to treat acute exacerbation. This is same as the COPD exacerbation, same as your asthma exacerbation. You can give this via nebulizer or MDI with spacer. Mind you, methyl xanthines are not recommended due to increased risk of side effect profile. This includes theophylline and aminophylline as well. Corticosteroids improve lung functions, oxygenation, and it shorten recovery time and hospitalization duration. Duration of therapy should be a short course, usually not more than 5 days. You can give oral prednisolone 40 milligrams once daily for 5 days. If the patient is not fit enough to take oral therapy, you can switch to IV hydrocortisone. What about antibiotics? This should be given when indicated, and it improves the recovery time, shortens the recovery time, reduce risk of early relapse, treatment failure, and hospitalized duration. Duration of therapy is again usually around 5 days, but this should be judged clinically. You can start antibiotics even if you don't have blood investigation. If the patient is having history of increasing sputum purulence, increasing sputum volume, and patient is dyspneic, you can start on antibiotics empirically. You can start with coamoxiclav, doxycycline, or macrolides. What about non-invasive ventilation? This should be the first mode of ventilation in COPD patients with acute respiratory failure who have no absolute contraindications because it improves gas exchange, reduces work of breathing, and the need of intubation. And also this decreases the hospitalization duration and improves the survival. So non-invasive ventilation is very important in COPD management. So what are the indications for NIV? You should have at least one of the following indications: respiratory acidosis with pH less than 7.35 and increased PaCO2 more than 6 kilopascal or more than 45 millimeters mercury. Or if the patient is having severe dyspnea with clinical signs suggestive of respiratory muscle fatigue, increased work of breathing, paradoxical movements of the abdomen, or retraction of the intercostal spaces, you can, which are features of exhaustion, you can start on NIV. Persistent hypoxemia despite supplemental oxygen is also another indication. So in terms of NIV, one thing I want to mention, this is non-invasive ventilation, is not CPAP, because I have seen some patients who are being given CPAP, if the NIV is bi-level positive pressure, it's not similar to continuous positive airway pressure. You may be giving it via the same machine, but it's not similar. The NIV, you give bi-level positive pressure ventilation. So what are the indications for invasive ventilation? If the NIV fails or contraindicated, you have to think of NIV. If the patient going into impending arrest, unprotected airway, refractory acidosis, you have to think of invasive ventilation. Other things you have to look for when you manage acute exacerbations, you have to monitor fluid balance and make sure the patient is adequately hydrated. If the patient is having heart failure, give diuretics, anticoagulation if the patient is immobilized, and post-exacerbation inhale therapy is very important. If the patient remains stable more than 24 to 48 hours, having saturation more than 90% in room air or with home oxygen, and patient is having adequate home support, you can plan the discharge. When you plan the discharge, you have to make sure you give steroids total of 5 days, maintenance, long-acting beta-agonist and LAMA, ensure proper inhaler technique. You have to always check the inhaler technique every time the patient admits with acute exacerbation. Smoking cessation, arrange vaccines, assess need for LTOT, arrange pulmonary rehabilitation, and proper follow-up. So the summary, in acute asthma, it's important to treat the patient with short-acting beta agonists. Steroids very important, oxygen therapy, controlled oxygen. In COPD, again, controlled oxygen is important to keep the target saturation 88 to 92%. Bronchodilators and steroids are important. NIV is crucial in COPD management. And you have to individualize the discharge plan for each and every patient. This is the end of my presentation. Thank you very much.
Moving on to my lecture now on bronchiectasis, do's and don'ts. So I hope to cover the definition, pathophysiology, clinical features, investigations, management, and future therapies in bronchiectasis. Right. So the reason why I like to talk about bronchiectasis, it's one of the most frequently mislabeled diseases in respiratory medicine. So I have seen many instances when you can't explain with asthma or COPD or any other very more commonly versed respiratory disease, someone would just write query bronchiectasis, and then that would become like an established label for that patient, right? So this is not an ad hoc label. There's a clear definition. There's a clear clinical syndrome, and there's a definite way of managing this condition. Okay. So the definition of bronchiectasis. Now there's a condition called cystic fibrosis, right? So cystic fibrosis. In cystic fibrosis, one of the main elements is bronchiectasis, but it's a more systemic condition, right? So when we talk about bronchiectasis and when we give general guidelines, we talk about bronchiectasis other than cystic fibrosis, because cystic fibrosis management is completely different in itself. Okay, so non-cystic fibrosis bronchiectasis, from here onwards would be referred to as bronchiectasis, is a chronic inflammatory disease defined as permanent dilatation of the bronchi. Okay, so you would see there are two diagrams here. One is a healthy airway, and the second one is an airway with bronchiectasis. So how I usually explain it is like it's a scarring of the airways. Okay, so fibrosis of the airways basically leads to this condition called bronchiectasis. So otherwise you would wonder what's the problem with a dilated airway. More dilated is better, isn't it? So we are giving bronchodilator, so permanently dilated should be good. But no, all this is because the airways are permanently scarred and dilated, and the natural clearance mechanisms of the airways are impaired. Okay, so airways are not just simple tubes, they are very dynamic structures. Okay, so there's a natural mechanism of maintaining the moisture and then clearing the sputum that collects, all of which is impaired in a scarred airway. Right. So then we talk about the clinical syndrome of bronchiectasis. So if we talk about the clinical syndrome, the patient must have a cough that produces sputum on most days of the week. There has to be a history of exacerbations and at least one of the following findings on HRCT, right? So these three radiological features that are described within the clinical syndrome are a ratio of the inner or outer airway diameter to the artery diameter of 1 or more, a lack of tapering of the airways, and the presence of radiologically visible airways in the perimeter. Okay, so I will be going through these things one by one, and I will show you diagrams as well. Right. So this is the pathophysiology of bronchiectasis. So this is actually quite an important slide, and this is what was previously called Cole's vicious cycle, or the hypothesis of a vicious cycle, right? So in the management of bronchiectasis, what we try to do is to break this vicious cycle at different points, right? So there's an initial insult, giving rise to a neutrophilic inflammation. And then there's airway destruction and distortion, what we call bronchiectasis, right? And then which leads to abnormal mucus clearance, okay? Which gives rise to mucus stasis. And then mucus is a very good medium for infection, right? So there's abundant bacterial colonization, okay? So in a patient with bronchiectasis, at any given time, if the mucus is not clear, these pockets of mucus act as a nidus of infection. So there's a whole lot of microbes just sitting there waiting to cause trouble. Okay, and they do cause trouble, and they do cause infections, which then gives rise to another round of neutrophilic inflammation and sets off this whole cycle once more. Okay, so this is what's called the vicious cycle or Cole's vicious cycle in bronchiectasis, and this is the one that we try to break when we manage bronchiectasis. Right, I'm sorry if this slide is not clear. So what this table has is a whole list of causes of bronchiectasis. So when you go through this list, you will realize that bronchiectasis is not a simple one-word entity. Okay, so there are so many insults that can subsequently lead to bronchiectasis. So we can't have one management plan for all patients, right? So if you go through this list, you find there are congenital abnormalities, right? And there are inherited disorders of ciliary function, okay? And there are enzyme deficiencies like alpha-1 antitrypsin deficiency. And then there are congenital abnormal airways. You might have heard of Ehlers-Danlos syndrome, which can give rise to abnormal airways, and immunodeficiencies, which can be either congenital or acquired, can give rise to bronchiectasis. And also this initial insult that I mentioned could be an autoimmune disorder. Right? Particularly known one is rheumatoid arthritis. Okay, so rheumatoid arthritis, so the inflammatory first hit is the insult of an autoimmune condition, but it sets off the same cycle, right? And then there are syndromes of recurrent aspiration, okay? And one thing that we have to always go hunting to look for is allergic bronchopulmonary aspergillosis, okay? And then there can be chronic, bronchiectasis can be a part of COPD, okay? So I mentioned all these causes, but within this table, I haven't mentioned the most common cause, which is infection. And in our setting, most commonly tuberculosis. Okay, so tuberculosis is not the only infection that can give rise to bronchiectasis. A whole lot of other infections, any severe infection can give rise to airway scarring, right? So it is a very, very heterogeneous condition, right? So even if you go hunting for a cause, even in the best of centers and despite extensive investigation, in many cases you can't find a cause, roughly 30 to 40%, right? But of those people who can find a cause, the most common etiology is post-infectious. And there are certain causes which are important to identify purely because they are treatable. Okay, so which include airway obstruction, non-tuberculous mycobacterial infection, allergic bronchopulmonary aspergillosis, and common variable immune deficiency. Right. Okay, moving back to the radiological features. So some quite obvious bronchiectasis can be seen on chest X-rays, but the preferred mode of diagnosis is high-resolution CT. And bronchiectasis is defined by bronchial dilatation as suggested by one or more of the following. So the bronchial tree, as you know, starts with a very thick tube, the trachea, and then progressively goes smaller and smaller and smaller towards the bedbed. Okay. So in bronchiectasis, there's permanent dilatation. So this natural tapering is not present. So what should taper is now not tapering. So you would have heard about the famous tram line shadows. So what are tram lines? Tram lines are parallel lines. So the bronchial tree is not supposed to go like in a parallel line. It's supposed to taper and somehow meet at some point, right? So when there's bronchiectasis, these airways can appear like parallel lines. Okay, and the first feature is broncho-arterial ratio of more than 1. So the bronchial tree is always accompanied by an accompanying artery, and the airway is smaller than the artery, right? So it reverses in bronchiectasis. The airway becomes bigger, right? So broncho-arterial ratio of more than 1 indicates bronchiectasis. And as I mentioned, the lack of tapering. And airway visibility within 1 centimeter of costal pleural surface or touching the mediastinal pleura. So the peripheral airways should not be visible. If you can see peripheral airways, you're looking at bronchiectasis, right? And then there are indirect signs like bronchial wall thickening, and there can be mucus infection, and you can have what we refer to as mosaic perfusion or air trapping on expiratory CTs, indicating that the smaller airways may be bronchiectatic. Right. So, so these are what are referred to as tram line shadows, right? Or these parallel lines. So these, so this particular the area in the bronchial tree, you can see it is not tapering towards the end, indicating bronchiectasis. So this is a clear picture of where the airway is larger than the accompanying artery. Okay, so what we call a signet ring sign. Okay, so the bronchial tree is wider in diameter than the accompanying pulmonary artery. And this is cystic bronchiectasis, which appears as a bunch of grapes on the CT. Okay, so how do you investigate this condition? So a confirmatory diagnosis can be achieved by radiology, by doing a CT scan. And then, of course, you have to investigate for a cause. As in all aspects in medicine, the most information comes from the history. So you have to take a thorough history regarding past infections, about the possibility of overlapping COPD and asthma, rheumatoid arthritis, inflammatory bowel disease, right? So assessment of immunoglobulin levels and basic assessment of a patient's immunity is in the British Thoracic Society guidelines as a first-line investigation for anyone with bronchiectasis. But this is not really practical in our setting, and we, in our clinics, we only offer for those who have a very young onset or very severe disease. But actually, it's whenever possible, we have to do this assessment as it is a treatable condition, right? And the other treatable condition is allergic bronchopulmonary aspergillosis. So this is a condition where you have an allergic response to fungal colonization, giving rise to bronchiectasis. So this usually occurs in patients with asthma or cystic fibrosis, and there are several classic radiological features, right? But in any patient with bronchiectasis, it's recommended to look for aspergillus sensitization, as it is very much a treatable condition and it improves the patient's quality of life. And you have to test for cystic fibrosis in those who have a younger onset, and when there's evidence of malabsorption, pancreatitis, or in the male male patients when there's evidence of infertility. And you have to also assess for ciliary dyskinesias if there's a history of neonatal distress, younger onset, male infertility, recurrent rhinosinusitis, and otitis media. You can see that all these features indicate ciliary dysfunction in different parts of the body. Okay, so another feature they have is they can have situs inversus, as ciliary function is important in the embryonic stage as well. And in all patients, irrespective of what their cause, sputum for culture is a must. Right? So this is very infrequently done, even in certain busy respiratory clinics, but all bronchiectasis patients should have sputum cultures done while their disease is stable. So this is very, very important, because then we have an idea about the kind of organisms that these patients are harboring. So when they come in with an exacerbation, we have to target the potential pathogens that were identified in their sputum while their disease was stable. Okay, so it's very, very important. And sputum for TB culture is also very important, particularly to identify the possibility of non-tuberculous mycobacterial infection. So why is this very important? So one particular clinical manifestation of non-tuberculous mycobacterial infection is bronchiectasis, where it involves the middle lobe and the lingular segment of the left side, what is known as Lady-Windermere syndrome. Okay, so we have tested many patients with middle and lingular lobe bronchiectasis, and I'm yet to identify a non-tuberculous mycobacteria in any of those patients. But it is a recognized clinical entity, and we have to go hunting for this infection and find it and treat it in those who have suggested radiology. Okay. And then there's targeted investigations. We don't offer this for everyone. So rheumatoid arthritis serology in those who have suggested clinical features, a confirmatory of GORD with pH manometry, bronchoscopy if we suspect a foreign body, or if we need washings for cultures if you're suspecting non-tuberculous mycobacteria, retroviral serology, screening for alpha-1 antitrypsin deficiency. All of these are only when clinically indicated. Right. Moving on to treatment. So what are the goals of treatment? So we have to try to break the vicious cycle, right? And we have to also prevent exacerbations. That again is part of the vicious cycle. That's what sets the cycle going. So each time you have an exacerbation, you set off another round of neutrophilic inflammation. Okay. So the other thing is the exacerbation itself is very, very harmful, and it has to be identified and treated early, right? Early and adequately. Okay, so this is, I think, where we are all failing, right? So most bronchiectasis patients, I will come to this, their exacerbations are not identified, and then they are given inadequate treatment, right? And then with bronchiectasis, as the disease progresses, we have to also focus on their quality of life and about advanced care planning and palliative care. Okay, so moving on to treatment. So for all patients, we need to educate the patients about their disease, right? So because for our patients, anything is seminal, right? So you have to tell them what their disease condition is, right? And general healthcare in terms of vaccination, nutritional support, smoking cessation, right? And then wherever there's a treatable cause, you have to address the treatable cause, okay? And airway clearance therapy is something that is mandatory for all. So all your bronchiectasis patients should be referred to the physiotherapy unit to be taught self-clearance measures, okay? So that is the number one step in bronchiectasis. So however bad the bronchiectasis is, if the patient can effectively clear their airways every day, their chances of exacerbations are quite low, okay? And then when it comes to the treatable causes, right? So like I mentioned, so there are certain things that we can really target and treat. So if there's an obstructed airway, find that, clear the obstruction. If there's an immunoglobulin deficiency, treat the deficiency. If there's ABPA, treat the ABPA. Right. Okay. So, right. So, airway clearance techniques, as I mentioned, is universal for all bronchiectasis patients. So these may be just methods of breathing and clearing that you treat the patients, ask the patients to do every day in the morning to clear their airways. Some patients need devices to help them with, right? So there are many commercially available devices which help to clear the sputum. Okay, and then some patients need oral antibiotics maintenance therapy, right? And then some patients need nebulized antibiotic maintenance therapy. I will go into the details of that, right? And in some patients, you need eradication of specific organisms, okay? And in some patients, there's a place for surgery. Okay, so in this chart, you can see a stepwise approach to bronchiectasis. In step one, like I mentioned, you have the pointer. Right. So you treat the underlying cause. You teach them airway clearance techniques and refer for pulmonary rehabilitation, offer vaccination, and prompt treatment of exacerbations, and give them a self-management plan. Okay. And then if it doesn't settle with this, you move on to step two. Okay, so you move on to step two. If with all your basic steps, if they still have 3 or more exacerbations per year, despite all the steps in step one, right, then you reassess and see if you can do anything else to treat and escalate their mucoactive treatment, right? And despite that, if they're still having more than 3 exacerbations per year, then there's a place for long-term antibiotics. And to decide on which long-term antibiotics, it's very important to find what they are harboring in the sputum. Okay, so it can be a pseudomonas organism or a non-pseudomonas pathogen. Okay, so if it's a pseudomonas, if it's a non-pseudomonas, the choice of antibiotic is azithromycin. Okay, so it's oral azithromycin given 3 times a week, a macrolide basically, right? So the macrolide of choice is azithromycin. Okay, and if it's pseudomonas, you have to give an alternative. So in the West, you give nebulized colistin, right, which we don't have here. It's very expensive. We can't afford to give. So there are quite a few of my patients who are on regular nebulized gentamicin, right? And then despite that, if they still have 3 or more exacerbations, you can combine both the inhaled antibiotic and the macrolide. And despite being on dual prophylaxis, if the patient is still having more and more exacerbations, more than 5 per year, there's a place for regular cyclical IV antibiotics every few months. Okay, so this is the stepwise approach to preventing exacerbations in bronchiectasis. Right. So what is the place for inhaled corticosteroids? You would see all bronchiectasis patients are on inhaled corticosteroids. That's only if there's coexistent asthma or COPD needing steroids, right? That being said, a lot of our patients do have coexisting asthma. And there are many points to consider before starting long-term antibiotics, right? So azithromycin, there are problems with azithromycin. Okay, so it can lead to vestibular problems. And with any long-term antibiotics, there's a problem of resistance, right? And in our patients, there can be a lot of non-tuberculous mycobacteria that we haven't identified. And one of the main drugs that we use for NTM is macrolides, right? So those are the problems with using azithromycin long-term, right? And with regard to nebulized antibiotics, even when we give it in hospital settings, ideally it should be given in isolation. As when we give an antibiotic nebulized, we're exposing the antibiotic to the whole ward if we're not in isolation. But with the ward facilities that we have, that is very difficult to achieve. Whenever you find pseudomonas for the first time, even if the patient is asymptomatic, we have to try to decolonize them by actively treating with antibiotics. It's very difficult to attempt eradication, but pseudomonas colonization is an independent poor prognosis factor for bronchiectasis. So we have to always try to eradicate pseudomonas. MRSA, we attempt to eradicate for public health reasons, basically, because there's a risk of spreading MRSA to all others in the vicinity, right? And then there's properly and timely introduction of pulmonary rehabilitation, LTOT, and domiciliary NIV. Right. This is one of the main take-home messages I want to tell you. So, identification of exacerbations. So, whenever you come across a bronchiectasis patient, ask them what their normal sputum volume and color is like. So, even on a good day, a patient with bronchiectasis will produce a certain volume of sputum of a certain color. Any change to that in terms of volume and color indicates an exacerbation. They need not have fever. They need not have any other features. Their WBC count, CRP, ESR, all that may be normal. But a change in color or volume of sputum indicates an exacerbation, and that has to be promptly identified and treated. Okay, so there are other, even pleuritic chest pain can be a feature of a bronchiectasis exacerbation, and that is due to their chronic colonization of a lot of sputum within their airways, right? So some of them can come up with this chronic pleuritic pain, which is very misunderstood among the community. It usually indicates a bad chest infection. Okay. Right, so you have to start antibiotics. So in stable patients, in those which are for which it's stable on oral antibiotics, sensitive to oral antibiotics, they may be started on oral antibiotics. Okay, but the duration is at least 14 days. Right, and if they are too ill and have to be admitted and started IV, then you can convert them to oral and discharge them. But please ensure that you give a course of 14 days. Okay, so this is adequate coverage for an exacerbation. So this is how we prevent progression of the underlying disease. So there are complications of bronchiectasis. These are just particularly notorious ones. Hemoptysis, they can have massive life-threatening hemoptysis. And these larger cavities can develop myxotomas, and subsequently they can go into respiratory failure. Okay, so this is again the vicious cycle revisited. Okay, so so the initial insult or subsequent insults, so you have to treat the treatable causes. Okay, and for neutrophilic inflammation, there is increasing evidence for the use of biologics, right? So brensocatib is now licensed for use in bronchiectasis, right? So then you have to adequately treat exacerbations, right? And to avoid the effects of mucus stasis, you have to teach them airway clearance maneuvers, right? And then for bacterial colonization, there is a place for eradication therapy in some and long-term antibiotics in others, right? So again, these are all the things that you can do for a patient with bronchiectasis. So it's not just giving inhalers, there's so much that we can do. So all the things that I mentioned are Western guidelines. So the challenges of implementing these are our facilities for CT scans are limited. Our culture facilities are limited. We rarely isolate anything in our patients with bronchiectasis, although we know they harbor a whole lot of microbes. And the options for nebulized antibiotics are limited. And our choices of available devices and preparations to discharge them on nebulized antibiotics at home is also limited. And we have a lot of fungal infections and mycobacterial diseases. Okay, so points to take home, I want to tell you the do's and don'ts. So don'ts are don't add ad hoc labels, right? So whenever you can't explain something, don't label it as bronchiectasis. Don't treat it like asthma or COPD, and do not inadequately treat an exacerbation. And do's, please diagnose, request for your CTs, investigate and treat according to guidelines whenever possible, and please refer to respiratory. Thank you.
I'm Dr. Chameera. I will be discussing regarding the wheezy child. Is it always asthma? Because we know that most of in the pediatric population, the wheezing is a very common presenting complaint. But most of the time, what we have done is that usually try to label them as this child is asthmatic, even though there are a lot of other differential diagnoses that we should consider if a child presented with the wheezing. So I will be discussing regarding the wheezy child and how do you approach a child presented with wheezing. Actually, wheezing is a very common in the pediatric, as I told you, and most of the time that is linked to asthma, but that is not always asthma. So that reason we should, I mean, that's necessary to have a very accurate diagnosis when we are dealing with the child with wheezing. Wheezing is a continuous high or the low pitch sound. So it's a musical sound and it's caused by the narrow airway. Typically, the wheezing we can hear in the expiratory, but it is usually actually biphasic as well. But most of the time, that is in the expiration. It is originate from airways of any size throughout from the proximal conducting airway. When considering wheezing, there are two types, either monophonic or the polyphonic. In the asthmatic patient, usually they can have this polyphonic wheezing. That is most of the time because of this obstruction of the pathology in the small airway or the peripheral airways. Regarding the wheezing of the infant or the preschool child, especially there are two main entities. Those are preschool wheezer as well as school age wheezer. The preschool wheezing is age less than 5 years. That is a bit of a challenging age because the most of these, even in the clinicians also, they are a bit the challenging age is this preschool wheezers because most of the time we are unable to that much of test right this spirometry and other things if the child is in the preschool age because for this test we need the cooperation and coordination very well. So because of that reason, we are struggling to diagnose an asthmatic child, especially less than 5 years. The other age group is the school age visa. They are aged about 6 years, about 6 to 12 years plus. Especially wheezing in the infant or the young children is a very common presenting complaint because we know that most of these viral upper respiratory tract infections are very common in preschool age or the age less than 5 years. So they are most of the presenting complaint is the wheezing actually. What they mention is that nearly for about 50% of child wheeze in some point of their during their early life. Preschool weeks affect one-third of the preschool children with a significant impact of the quality, especially school abstinence and night sleep awakening and those kind of problems may be there with the wheezing. So keep in mind that all preschool wheezers do not have asthma. Regarding preschool wheezing, the first thing we should identify, is it really wheeze? You know that most of these parents come and tell to us that Dr. My child is having wheezing or Dr. Baba wheeze එක තියෙනවා. So first of as a medical officer or the practitioner, the first thing you should identify whether this is actual wheeze. There may be upper obstruction, maybe a noisy breathing, maybe a stride, or maybe a croup. So parents may misdiagnose or misunderstand this as wheezing. So whenever possible, I would suggest you that with these days we have these smartphones. Just take a video. I mean, just show a video of a child with wheezing. Show the parents if your child is having this kind of a breathing pattern. I think that then we can get an idea of actually this child is having wheezing. Sometimes child may having just upper airway obstruction, maybe a stridor. Parents may be misdiagnosed and misinterpret it as wheezing. The second thing is it's not always bronchiolitis. We know that bronchiolitis is very common if the age is less than 2 years. So whenever child presented to us, before label this child is as asthmatic, try to get an idea whether I'm dealing with a child with a normal bronchiolitis, a very normal following a viral condition, it's a very normal phenomenon, very common in the preschool age. What they mention is that usually up to 8 to 10 attacks of viral upper respiratory tract infections are very common during the preschool, and that symptoms may last for about 2 to 3 weeks. So you don't need to worry. There is a very new other entity called nursery school syndrome. You may have heard about it, Scratches syndrome. So what they mention in this syndrome, actually it's not a syndrome, it's a phenomenon kind of a thing. Usually that affects to the first child, early placement in the daycare centers. You know that parents very frequently come and complaining that Dr. My child is having recurrent viral infection, recurrent wheezing, always getting this cough and cold very frequently. Why the reason? So that may be the main, and the other thing is actually these are viral infection. They are not responding to the antibiotics or the corticosteroids. So the reason is actually this immaturity of the immune system. They get affected with frequent of this viral infection. Other thing is the viral infections are very common during this age less than 5 years. So the things actually regarding this nursery school syndrome, the things what you can do is the first important thing is keep in mind that whenever parents had a concern regarding their child with the recurrent wheezing or any respiratory pathology, you should take a very detailed history to exclude any pathological problem. We don't know we are dealing with any kind of a chronic lung disease problem. So the first thing is take a detailed history and thoroughly examine the child. Then look at the weight of the child, weight gain is everything is okay, nutrition is okay. So then if you are pretty sure with that, you are dealing with a normal child with normal viral respiratory tract infection, the first thing is you have to reassure the parents that telling that this may be a normal phenomenon. because your child is immature, your child's immune system is low at this level. So it's very common to have this repeated viral infection. The thing is nutrition, hydration, and if there is any nasal obstruction, you can give some nasal drop for a short period of time. And then if it is a really troublesome, they recommended of giving this annual influenza vaccine as well. And in our EPI schedule, we don't have this pneumococcal vaccine as well. So if there is any concern with the repeated hospital admission, this kind of illness, because there may be a secondary bacterial infection. So you can, that you can suggest them to have annual influenza or the pneumococcal vaccine in this kind of situation. So whenever a child presented to us with a wheezing or a cough, we can put them child either one of these 5 categories. Each any problems child presented to us, either that child may, the one category is that child may be a normal child. So you don't need to worry. Maybe a simple recurrent viral upper respiratory tract infections, which lasts for about 2 to 3 weeks duration with persistent cough. That may be most of the time wet cough. And the other thing is early stage of the pertussis also, they can have, that the pertussis have 3 different phases. In the paroxysmal cough stage, usually they can have these repeated bouts of coughing. So that child may having that illness or a nursery school syndrome. The second category is asthma syndrome. That's what I'm going to discuss with you. This asthma syndrome, actually nowadays we are calling them a syndrome because it's a spectrum of disease. It's not a single disease. So they can present it with either episodic viral visa or the multiple trigger visa. The third category is that child may having some serious illness like bronchiectasis, childhood interstitial lung disease, or the cystic fibrosis. Other things may be a very minor mimics of the exacerbation like gastroesophageal reflux or the allergic rhinitis. The last one may be the ovancious parents like firstborn child. So whoever the child presented with the wheezing or the recurrent wheeze or the cough, you should be able to categorize or put them child in either one of these category. This article actually a little bit article in 2007 regarding wheezing in the older children. They have done an evaluation in the worldwide trend of the prevalence of asthma symptoms in the preschool age of the older children. So the conclusion is actually what they mention is that the global prevalence of the wheezing is around 11% in the children aged 6 to 7 groups and 13% in the children aged 13 to 14 years. So now let's talk about how we approach a child with the wheeze. There are 2 types of wheeze we can categorize. That child can have the acute wheeze or the chronic wheeze. The acute wheeze is usually start and that progress within hours or days, and that can be either infective or the non-infective. The other chronic or the recurrent wheeze can have either structural malformation, a structural problem, or the functional pathologies. So what are the infective causes of acute wheezing? So bronchiolitis is very common in the preschool, especially if the child is less than 2 years. The second one is the community-acquired pneumonia. That can be either atypical infections like mycoplasma or maybe a viral pneumonia. Then you should keep in mind that you may be dealing with a child with laryngotracheal bronchitis or the viral flu, or maybe bacterial tracheitis, epiglottitis. These can also present as acute wheezing episode. Those are the infective causes. Little bit about this viral bronchiolitis I would like to share with you. This, that's very common age below 2 years, very common with first 18 months of life. It's the commonest cause of wheeze below the age of 2 years, and this child can present with the wheeze, rhinorrhea, cough, intermittent fever, poor feeding, nasal congestion, as well as the child can have usually what they mentioned, this child is having wheezing throughout the lung, and there are some on and off crepitations as well. So what is the management? What are the management options available for the viral bronchiolitis? The thing is that it's viral, usually it's a self-limiting. So only the supportive care, that if the child is having any apneic attack or the desaturation, we can give some oxygen support. Usually at this level, if you are pretty sure with that this child is having bronchiolitis, chest X-ray is also not indicated. But keep in mind that whatever the things, if you are suspicious this child is having kind of a pathological event, you can do a chest X-ray as well, because we don't know if the air entry is not equal, if there is any added sounds, if the child is toxic looking. It's that's justifiable to do a chest X-ray at this level also. But if it is clear-cut viral bronchiolitis, no need of doing imaging as well. Antibiotics are not indicated. So this regarding this nebulized with salbutamol, nebulized with 3% saline, even giving antibiotics, antiviral, giving hydrocortisone or the corticosteroids also doesn't have any proven benefit of managing child with the viral bronchiolitis. But you know that in our setup, to be honest with you, sometimes we have to give, we are nebulizing with this child with the 3% saline and giving salbutamol. Even we are pretty sure with that we are dealing with the child with the viral bronchiolitis. Sometimes actually in the data or the articles telling that in the viral bronchiolitis, the pathology is not basically due to the bronchospasm, but they mention is the mucosal edema and lot of secretions, mucus secretion. So actually giving this beta 2 agonist is not going to help at that level because there is no any bronchodilator effect. I mean that we are giving beta 2 agonist to get a bronchodilator effect, but in the viral bronchiolitis that cannot helpful. But some in the hospital setup, sometimes we try to give this salbutamol nebulization with the 3% saline nebulization, but they doesn't have any proven benefits. So what are the non-infective causes of acute wheezing? The most common one or the famous one is the foreign body aspiration. We know that especially in the toddler age, if the child presented with the acute onset of bout of coughing, with sudden onset of wheezing, and if you are concerned the child is having unilateral wheezing or unequal breath sounds, think about the foreign body aspiration, even though there is no any clear-cut history about whether the child has played with the toys or any other things, because sudden, I mean, the hidden silence foreign body aspiration may be possible. The other important thing, we know that most of this foreign body aspiration is common in the right main bronchus. The reason is the right main bronchus is more vertical and it's very wide. But in the pediatric, when we are doing the bronchoscopy, rigid bronchoscopy, that we have identified that even though it's not confined to the right main bronchus, that can be anywhere in even in the left main bronchus, you can see these foreign bodies. Regarding this chronic or recurrent wheezing, this article is all about long time ago, 1995. So they have evaluated the wheezing in the early childhood. So the conclusion that they have given us, the most likely diagnosis in children with recurrent wheezing is asthma. Whenever a child presented to you with the recurrent episodes of asthma wheezing, you should keep in the first differential diagnosis should be asthma, no doubt about that. But there are other differentials that you should consider as well. So what they mention, regardless of the time of the onset, whether the child is having atopy or not, whether there is any precipitating factor, whether the child is having family history or not. If the child is having recurrent or frequent wheezing episode, think about asthma as the first level, as the first differential diagnosis. So what are the other causes of recurrent wheezing in a child? We can categorize them as either structural abnormalities or the functional pathologies. The structural abnormalities in the pediatric population, there can be tracheobronchomalacia, tracheal stenosis, tracheal web, vascular compression or the vascular ring. There can be a lymphadenopathy, especially in the pediatrics, common in the lymphoma. They can present it with the compressions of the airway. There may be a retained airway foreign body as well. What are the functional abnormalities? Those are aspiration syndrome like gastroesophageal reflux disease, bronchopulmonary dysplasia, bronchiolitis obliterans, pulmonary edema, child may having chronic suppuratory lung disease like cystic fibrosis, pulmonary celiac dyskinesia, or the interstitial lung disease. So what are the features more favoring asthma? You know that we are very tend to give the label of asthma when the child presented with the wheezing. So if the child is having this episodic wheezing with typical triggering factors like if the wheezing or the cough is happen with the coughing, laughing, dancing, playing, if there is any night awakening with the cough, whether there is any seasonal variation, if there is a personal history of atopic eczema, allergic rhinitis, if there is family history of asthma or the atopy. And the other important thing I want to discuss with you, share with you, that the good response to the treatment trial. I will be discussing this with you later. So if the child is having very good response to low dose inhaled corticosteroids we can give for about 2 to 3 month duration, and the child is having very good response, that indicate the child is the most possible diagnosis is asthma. When you are clinically suspect asthma, actually we can do some tests to get an aid to aid our diagnosis. The problem with doing this test, as I told you earlier, even if the GINA guideline they recommended to diagnose asthma, you should have the clinical signs and symptoms as well as you should show the airflow expiratory airflow limitation. You have to do the spirometry or the free flow meter to assess whether the child is having expiratory airflow limitation with the bronchodilator reversibility. That's a normal thing if the age is above 6 years. The reason is the spirometry and the free flow meter, you cannot do the child below 5 years because, as I told you, that needs a very good coordination and the cooperation. But to assist the diagnosis, we can do the lung function test, free flow meter assessment, and exhale nitric oxide. This exhaled nitric oxide is a non-invasive thing. Usually, this nitric oxide is produced in the nasal mucosa, the respiratory epithelium. So, when the exhale air that contain this nitric oxide. To assessing the nitric oxide, we can get an idea whether the child is having eosinophilic airway inflammation. In the pediatric population, if the feed value is the exhaled nitric oxide value is more than 35 particles per million, that's indicate of child is having eosinophilic airway inflammation, and that child indicate us that child is having a good response to the inhaled corticosteroids. Apart from that, actually, to diagnose the asthma, you don't need to do a chest X-ray. But if you are thinking other alternative diagnosis, you can do a chest X-ray as well. Other things to test to allergic sensitization and blood and sputum eosinophilia. This thing I want to share with you a little bit. This blood and sputum eosinophilia, you know that there are a lot of asthma phenotypes and the genotype is there. The common one is this eosinophilic inflammatory pathway. So they are, if this in the asthmatic child, even in the adult population, their eosinophilic count is a bit high. So if you had a doubt whether this child is having asthma or any other things, actually you can do a full blood count. That is not harm, because we cannot do each and every child to undergo a bronchoscopy, do the ball and the eosinophilic count in the ball, but you can do a full blood count to assess the eosinophilic count. So this research they have done in 2021. They have evaluated 136 children aged 1 to 5 years. They have undergone elective bronchoscopy. These 130 out of this 136, the 105 was having recurrent severe wheezy. The rest of 31 was a non-wheezing respiratory diseases. Actually, the conclusion of this research was that the blood eosinophilic and allergic sensitization was significantly high in recurrent severe wheezy rather than non-wheezy respiratory illnesses. Other things like lower airway inflammatory markers and pathogen detectors were similar in both groups. And pathogen profile, they have identified the most common one in this population for the recurrent severe wheezy is having the respiratory syncytial virus and the varicella as well. Other thing is episodic viral wheezy or the multiple trigger wheezy. There is no any difference between the inflammation or infection markers. Other thing is we can assess peripheral blood eosinophilia. In their document, they mention more than 300 cells micro per liter is helped to identify preschool children who is responding to inhaled corticosteroid. But in our population, to be honest with you, in the Nielsen test book of the pediatrics, the eosinophilia definition they are giving more than 500. If the eosinophilic count more than 3 to 500, that is eosinophilia. But the problem with this eosinophilia, you know that even with the parasitic infection, even with the allergic rhinitis, even with the atopic eczema, that can also having high eosinophilic count. So that is not a confirmatory test to tell that this child is having asthma, but you can get an idea that this child is having eosinophilic inflammation. This child may respond to inhaled corticosteroid. So wheezing in children 5 years and younger, can we diagnose asthma at this age? Even in the GINA guideline, the latest one is 2025. This latest guideline, they have stressed more regarding the diagnosis and the management of child less than 5 years rather than in the previous updates. Here actually, previously we struggled to get a diagnosis of asthma if the child is less than 5 years. The reason is, as I told you, their clinical presentation may be different. We cannot assess expiratory airflow limitation by doing spiro and other things because the coordination is needed. Then they have done systematic review and they have evaluated 23 guidelines on the management of preschool wheezing, and the conclusion is actually the immense majority accepted that the asthma can be diagnosed from the first year of life without requiring pulmonary function test or other complementary tests. The other important thing is the response to treatment and the exclusion of other alternative diagnoses are the key element for the established to get the diagnosis. That is a very important thing because we know that it's a practical when you are doing the hospital setup also. We are not very much sure whether this child is having just a viral wheezing or this child is going to have asthma in later life. So at that level, they have given us the way or the pathway to do. You can do this one, and then you can get an idea whether your child end up with asthma. This is the latest this is the latest guideline regarding the diagnostic criteria for the diagnosis of asthma below 5 years. It's a very good. I think this is a very good slide. What they recommend to get a diagnosis of asthma, especially less than 5 years, your child should fulfill all three criteria. The first one is child should have the recurrent acute wheezing episode, minimally 2 episodes per year. Or if the child is at least having one wheezing episode with the asthma-like syndrome in between, the child is having cough and difficulty in breathing in between, plus we should we should exclude other differential diagnosis. I mean that other bad pathology before get a confirmatory diagnosis of asthma. Plus the important one is this last one, timely clinically response of respiratory symptoms or signs to asthma medication. What they mention, if suppose that your child presented with the acute wheezing episode, you are just in the hospital setup, you are just giving nebulized with the salbutamol, and you saw the child has a very good response within 30 to 60 minutes. That's mean that the timely clinically response of asthma. Or in the if you had happen to give IV hydrocortisone and corticosteroids, if the child is responding within next 3 to 4 hours, that is also indicate that the child has a timely clinical response. Or at hospital in the ward in the home setup, if you are giving nebulized with MDI and the child is respond very quickly with the MDI salbutamol, and that's indicate child is having timely clinical response. The other important thing is reduce frequency or severity of acute wheezing by giving a trial of low dose inhaled corticosteroid for about 2 to 3 month duration. So what you can do is, I mean that as a medical practitioner, if you are not sure with whether this is pre or asthma or not, if your child is fulfill this criteria, you can try of giving in low dose of inhaled corticosteroid for about 2 to 3 months and get them back for 2 to 3 months later with the asthma diary. And if you find that the asthma symptoms has reduced significantly and the frequency is reduced with the inhaled corticosteroids, then actually most of the time you are dealing with the child with asthma. Then you can go for a stepwise management, whether you are using this ICS inhaled corticosteroids plus SAB as needed, or you can escalate the treatment therapy. The problem with the challenge thing, as I told, is the diagnosis of asthma below 5 years. I mean that this will help us for that. What are the features? What are the features more fair of alternative diagnosis? Suppose that if your child is having asthma or the wheezing episode since birth, since day 1 of life, day 2 of life, with the symptoms associated with feeding, choking episodes, wheezing with a little cough, or child is having productive cough, if there are any recurrent infections, pulmonary infection, meningitis, skin abscess, suggestive of any immunodeficiencies, of the child, the weight gain and other things are very poor. Also, the child had a poor response to the inhaled corticosteroid trial, then at that level, you should think about, I'm not dealing with a child with asthma, there may be an other alternative diagnosis. The other things for the recurrent is the structural abnormalities. There are a lot of, I would like to discuss with you regarding congenital tracheomalacia. It's very common during first 2 to 3 months of life. Usually they presented with the noisy breathing. They've been born with cold. Usually they have this biphasic stridor with the monophonic Bs. They can have the croup-like cough. They are can associate this congenital tracheomalacia, tracheobronchomalacia can be associated with tracheobronchial fistula, esophageal atresia, congenital diaphragmatic hernia, congenital pulmonary artery malformation. There may be other associated congenital malformation as well. Actually, the management is medical and the surgical, but in Sri Lanka, in our setup, for the congenital tracheobronchomalacia kind of things, actually, we don't have surgical options available as far as I know. We can do this tracheobronchoplasty or the iotoplasty or giving this putting silicone stent kind of a thing, but as far as I know, we cannot do those things at our setup, even at LRH also. So the medical management actually we can give for about long period of time CPAP, positive airway pressure we can give to support the child. Because I have seen a child at LRH MICU, we had a child with the tracheobronchomalacia, nearly for about 30 days child. We don't have any other option, the surgical options, cardiothoracic surgeons were unable to do those things. So actually we gave this CPAP for about 2 to 3 months. Child had a very good response. We were able to excubate the child as well. So in our setup, actually the things, because the lung is, the advantage of the pediatric in the infant lung is growing. So we have to give them a time to resolve and remodel. So most of the time giving this positive pressure for about long period of time will solve all the problem. Other diagnosis for the cause for the recurrent wheezing, the chronic subarachnoid lung disease. You know that can be either cystic fibrosis, pulmonary dyskinesia, maybe immunodeficiencies. You should suspect these things. If the child is having poor weight gain, or if your child is having recurrent infection, if as the previous lecture mentioned you that the child is having congenital heart disease problem like dystrocardia or the signs of inmersion, you should think about the fibrocystic dyskinesia, or maybe meconium ileus or the prolonged jaundice, then you should think about the cystic fibrosis. So these are the other things we should consider if a child presented with the recurrent wheezing. Wheezing due to aspiration also are very common. Especially we know that especially this population is the high risk. So the child is extreme premature, post-thoracic surgery, syndromic child, or the neuromuscular disorders like cystic fibrosis or any other neurodevelopmental disorder child. If the child is having recurrent wheezing episode, think about the aspiration, because the silent aspiration is very common among this population. The things we can do a lot of things for these children. The alternative feeding is a very good method, but before that we can do simply FOL, we can do the milk scan, then we can do the video thoracoscopic swallowing assessment, which is called VFSS, to get an idea about whether the child is having any swallowing difficulty. At which age the swallowing is problem, so we can attend to that problem as well. So the alternative feeding is a one-off option. Little bit about the bronchiolitis obliterans. It is common in the actually it's not common in the pediatric population. In the developed countries, following a bone marrow transplantation or even in the lung transplantation, they can happen. But in other countries, in the pediatric, most of following the force infectious, like following either adenomeasles, rhinoviruses, they can have this bronchiolitis obliterans. So my take-home message is recurrent wheezing is very common in the pediatric population, and most of the time maybe due to asthma, but it's not only the diagnosis. So whenever child presented to you with asthma, don't hesitate to reconsider or change your diagnosis. Whenever each and every clinic visit, please reassess your child. And if you are thinking that the inhaler technique is good, dose is good, and everything is good, then think about whether I am dealing with a child with another alternative diagnosis. Don't put a child for a long period of time with the inhaler thinking that technique is wrong, space is not working. Just each and every clinic visit, reassess, and do not hesitate to change your mind. I mean, that it's a good benefit to the child. So thank you very much.